Um, Welcome back to the deep dive. I want to start today with a mental image for you. So think about a street map of your city.
Okay.
You know that Fifth Avenue is, well, it's always Fifth Avenue. The Eiffel Tower doesn't just decide to move 3 blocks south on a Tuesday. We really rely on geography being fixed.
Right. It gives us this sense of security. I mean, we like to believe the physical world, and by extension, our own bodies are these standardized, reliable machines.
Exactly. But today, we're diving into a stack of research on rectal cancer staging. Specifically, this paper titled Anatomic Basis of Rectal Cancer Staging. And it turns out that map, it's kind of a mess.
Yeah, it really is.
It's full of disputed borders, fuzzy lines, and what essentially amounts to territory skirmishes between different types of doctors.
It is. And to extend your metaphor, in the world of rectal cancer, misreading that map doesn't just mean, getting lost or missing your exit. It means potentially overtreating a patient with toxic radiation that they didn't actually need. Or, conversely, undertreating a tumor that is much more dangerous than it looks on the surface.
The stakes are just incredibly high here. We aren't just talking about anatomy for the sake of passing a med school exam.
No, not at all.
We're talking about how high-resolution MRI has moved from just taking pretty pictures to actually dictating life-changing decisions for you or your loved ones.
Precisely. Because we are seeing a massive divergence in treatment paradigms right now.
Right.
On one hand, you have patients receiving what we call total neoadjuvant therapy.
And that's the heavy stuff, right?
Very heavy. It's a grueling regimen of chemotherapy and radiation before surgery even happens. But then, on the other hand, we have patients who can skip radiation entirely and just go straight to surgery.
And see, before reading this source material, I assumed the deciding factor was just, I don't know, size.
Yeah.
Is it the size of a grape or a walnut?
Yeah, that's what most people think.
If it's big, nuke it. If it's small, cut it out.
It's a common intuition, but it's completely outdated. It is no longer just about size. It is entirely about location, location, location.
But that brings us to the central conflict in the paper.
Yeah.
The authors describe this sort of Tower of Babel situation in modern medicine.
I really appreciated that comparison in the text.
It's so vivid. You've got surgeons, pathologists, radiologists, and they're all looking at the exact same pelvis, looking at the exact same MRI. But they're speaking completely different languages.
It sounds absurd when you put it that way, but it's true. They literally cannot even agree on basic questions like, where does the rectum start? Or what is the anal canal?
And that is exactly where I want to start our dive today. Because if the experts can't agree on where the organ starts, how on earth can they agree on how to treat it?
Exactly.
The paper opens with a question that I honestly thought I knew the answer to, which is simply, what is the anal canal?
It's such a deceptive question because if you ask an anatomist, so someone looking under a microscope, they will tell you the anal canal is actually quite short. They define it by the cells. It's lined by squamous epithelium, think skin-like cells, and it ends right at the dentate line.
The dentate line, that's that little serrated zigzag line inside the anatomy, right?
Correct. It literally looks like a jagged edge. For an anatomist, once you cross that line and the cells change over to mucosa, you are in the rectum, period. Case closed.
But the surgeon strongly disagrees with that.
Oh, the surgeon looks at that textbook definition and says, that is completely useless to me.
Why?
Surgeons don't really care about the microscopic cell type. They care about function. They define the surgical anal canal as a much longer functional unit.
Okay, so how long are we talking?
It extends from the anal verge all the way up to the anorectal ring, which is the puborectalis sling.
So the surgeon's canal is significantly longer than the anatomist's canal.
Okay.
It's like the anatomist says the tunnel ends at the toll booth, but the surgeon says the tunnel ends when you actually see daylight.
That's a great way to put it. And the source argues very strongly that for cancer staging, we absolutely need to be using the surgical definition.
Is that just about surgical ego, or is there a real reason?
No, it is entirely about consequences for the patient. The surgical canal includes the sphincter complex. Those are the muscles that control continence.
Oh, wow.
Okay, right. If a tumor is in that zone, a zone the anatomist might just call the low rectum, but the surgeon calls the anal canal, it directly threatens the patient's ability to control their bowel movements.
That is a harsh clinical reality.
It is. If we stick to the shorter textbook anatomic definition, we might miss the fact that a tumor is invading those critical muscles. And if you lose those muscles in surgery, you lose the ability to use the bathroom naturally.
You end up with a permanent colostomy bag.
Yes. So defining the territory correctly right off the bat dictates the quality of life for the patient forever.
Okay, so we have a major disagreement at the bottom exit. But speaking of measuring things, the paper brings up this old-school method of defining the top of the rectum using a rigid ruler.
Ah, yes, the famous 15-centimeter rule.
I have to admit, this sounded a bit medieval to me when I read it.
It is a bit archaic.
So the old logic was you stick a rigid scope inside, and anything from 0 to 15 centimeters is classified as the rectum. Anything above 15 is the sigmoid colon.
Right.
It seems so simple. Why was this the gold standard for so long if it's so incredibly flawed?
Honestly, it was born out of sheer necessity. Before we had these incredible high-res MRIs we use today, surgeons were essentially operating blind.
Right. They couldn't see through the tissue.
Exactly. A rigid scope was the only tool they had to map the territory. They just needed a hard number to work with.
But humans aren't standardized products coming off an assembly line.
And that is the fatal flaw. Humans vary wildly in height, pelvic shape, body habitus. Just imagine a tall, lanky basketball player.
Okay, I'm picturing him.
In him, 13 centimeters on that ruler might still be deep down in the pelvis, well within the rectum.
Makes sense.
Now picture a petite, elderly woman with a curved spine.
Oh, I see where this is going.
Right. In her, 13 centimeters is probably way up in the belly. It is clearly the sigmoid colon. But if you blindly use the rigid 15-centimeter rule, you are diagnosing her with rectal cancer when she actually has colon cancer.
And that isn't just a paperwork labeling issue. That completely changes the treatment plan, doesn't it?
Drastically. Rectal cancer often gets heavy radiation because of where it sits tightly in the pelvis. Colon cancer usually just gets surgery.
So you could be radiating someone for no reason.
Exactly. You do not want to radiate a colon tumor if you don't have to. It's toxic, it damages bowel function, it can destroy fertility.
So the ruler is out. We are officially throwing away the rigid ruler. What do we use instead to find the top border?
The source advocates for a personalized landmark called the sigmoid takeoff, or STO.
The sigmoid takeoff. It sounds like an exit ramp on a highway.
That is actually the perfect way to visualize it. Think of the rectum as being stuck against the sacrum, which is your backbone.
Okay.
It's retroperitoneal, meaning it is glued in place, it cannot move.
So the rectum is the highway permanently stuck to the ground.
Right. The sigmoid colon, however, is mobile. It kind of flops around in the belly. The STO is the exact geometric point where the bowel takes off from the rigid sacrum and flexes forward to become mobile.
So instead of looking for an arbitrary number on a ruler, the radiologist is looking for that specific bend in the road on the MRI scan.
Correct. Or let's say the tumor is massive and distorts that bend so you can't see it clearly. Then you look at the blood supply.
A blood supply changes there?
Yes, the sigmoid arteries diverge from the superior rectal arteries at that exact same level. So using the STO ensures we are treating the patient's actual individual anatomy, not a statistical average.
I love that. It's personalized medicine, but achieved through geometry.
It really is.
Now, let's move down the track a bit. We've defined the top and the bottom, but there's a line right in the middle that seems to be the most critical border of all. The APR.
The anterior peritoneal reflection. Yes, this is the great divide of the pelvis.
And the paper mentions it has a surprisingly poetic name in radiology. The seagull.
The seagull sign, yes.
I was trying to visualize this when I read it. Are we talking about an actual bird shape inside the pelvis?
It's a trick of the light, or rather a trick of the peritoneum. When you look at an axial MRI, which is that cross-section view like you're slicing a loaf of bread,
Right.
you scroll down to where the peritoneum reflects off the bladder, or the uterus in women, and drapes onto the rectum.
Okay, I'm with you.
Right at that reflection point, it creates this distinct, bright V shape on the scan. To radiologists, that V looks exactly like the wings of a seagull flying towards you.
Okay, I can picture the wings. But why is the seagull such a boss? Why does a V shape get to decide the whole treatment plan?
Because that bird acts as the border guard. It separates the rectum into two completely different worlds with entirely different rules of engagement.
Let's talk about the world above the wings first.
Above the APR, above the wings, the rectum is wrapped in the peritoneum. It's like it's wearing a protective coat. And critically, the pelvis widens out up there. There is physically more space.
Which is good for the surgeon, I imagine.
Very good. Because even if a tumor breaks through the wall of the bowel up there, It's floating in a safer, wider cavity.
So tumors above the line usually get to skip radiation.
Increasingly, yes. The data shows that for upper rectal tumors, those above the Siegel surgery alone is very often curative.
And below the wings.
Below the APR, the rectum is naked.
Naked.
No peritoneal covering at all, no coat. It is just the rectal wall, a thin layer of fat, and then the mesorectal fascia. It sits intimately close to the pelvic sidewall, the major nerves, the blood vessels.
Which sounds incredibly vulnerable.
It is extremely vulnerable. If a tumor breaks out down there, there's absolutely no safety buffer. The risk of local recurrence, meaning the cancer coming back right there in the pelvis, is incredibly high.
Wow.
That's why tumors below the Siegel almost always get the full heavy artillery, the chemo, and the radiation.
It's just amazing to me that one single V-shape on a scan basically acts as a traffic cop, sending patients down two completely different life paths.
It really does. It effectively divides the surgical rectum from the medical rectum.
Which brings us to the next layer of the onion, or maybe I should say the wrapper. We need to talk about the mesorectal fascia, or the MRF.
The MRF is basically the holy grail of rectal cancer surgery.
The paper describes it almost like an envelope, right?
Yes. So think of the rectum as a tube. Surrounding that tube is a layer of fatty tissue that contains all the local lymph nodes and blood vessels. And wrapping around all of that, like saran wrap, is the mesorectal fascia.
And the goal of the surgery, this total mesorectal excision that everyone talks about in the paper, is to remove that whole package without tearing the saran wrap.
Exactly. You want to take the package out whole. Because if you tear the wrapper, you might still microscopic cancer cells right back into the pelvis.
But here is where reading the MRI gets really stressful. The source mentions a very specific tiny number here, the 1 millimeter rule.
This is one of the most robust and unforgiving findings in the entire literature.
Really?
Yes. If anything suspicious, a tumor, an enlarged node, a deposit is within just 1 millimeter of that fascia on the MRI, it is considered involved.
Just 1 millimeter. That is razor thin. I mean, why not give it more buffer? Why not say 5 millimeters just to be perfectly safe?
They actually tried that. Some early studies looked at using a 5 millimeter buffer. It sounds safer.
It sounds much safer.
But it completely backfired.
How so?
It created way too many false positives. Radiologists were constantly telling surgeons, oh, the margin is threatened, it's within 4 millimeters. So the patients got blasted with heavy radiation.
Right.
But then when they did the surgery and looked at the actual tissue under a microscope, the margin was completely clear. The tumor hadn't reached the wrapper at all.
So they were overtreating thousands of people based on a safe buffer.
Exactly. The 1 millimeter cutoff turned out to be the sweet spot. It perfectly balances accuracy with avoiding unnecessary toxicity for the patient.
Now, speaking of things getting dangerously close to the edge, the paper describes something called the comet tail sign. That really stuck with me. It sounds beautiful, but I'm guessing in oncology, beautiful usually means bad.
You guessed right. It is very bad news. It's a classic sign of a tumor deposit.
What does it actually look like?
Imagine a nodular mass sitting in the fat, but it's not round and smooth. It has this spiculated trailing tail that follows along a blood vessel.
Like a comet.
Exactly. It looks like a comet streaking through the night sky.
If that comet is flying near the envelope.
If that comet tail is within 1 millimeter of the MRF, the risk of recurrence skyrockets. It is treated as a positive margin. It changes the entire surgical plan.
Before we move on to the nodes, I need to clear up some alphabet soup from the text. The paper makes a really big deal about distinguishing the MRF from the CRM.
Ah, yes.
I'll be completely honest, I thought they were synonyms. Aren't they the exact same thing?
That is the classic trap, and it's exactly where the confusion happens in tumor boards. MRF is anatomy. It's that fixed fascial envelope, the saran wrap, that physically exists in every single person.
Okay.
CRM stands for circumferential resection margin. That is surgical. It's where the surgeon actually cuts.
Okay, break that down for me. What's the difference in real-world practice?
Usually, the surgeon tries to perfectly follow the MRF, so in a standard case, the CRM is the MRF. They are just peeling along that natural plane.
That makes sense.
But let's say the tumor is super aggressive. It has actively eaten through the MRF and into the surrounding muscle or the pelvic wall.
So the wrapper is completely broken.
Right. In that scenario, the surgeon can't just follow the wrapper anymore. They have to cut much wider, maybe taking out part of the muscle or even shaving off part of the sacrum.
Oh, I see.
In that case, the CRM, the actual cut surface the pathologist looks at, is entirely distinct from the MRF.
I get it now. So the MRF is the map, but the CRM is where the road crew actually decides to dig the trench.
That's a great analogy. And radiologists need to purely describe the anatomy, the MRF, and let the surgeons decide where they're going to cut the CRM. Using those acronyms interchangeably just confuses everyone in the operating room.
Okay, let's get into the really messy stuff now, the gray areas. Specifically, what happens when the tumor starts invading things that aren't quite the rectum, but aren't quite other organs either, like the sphincters?
This is where that Tower of Babel comes back to haunt us. If a low tumor hits the external sphincter muscles, how do you stage it? Is it a T3 tumor, meaning it's contained, or a T4 tumor, meaning it's invading other structures?
The paper notes that the official cancer staging manual, the AJCC, is basically silent on this, which seems wild for such a major guiding document.
It's surprisingly vague, yes. But the College of American Pathologists, or CAT, is much stricter.
What do they say?
They state that if it hits the external sphincter or the levator antemuscle, that is definitively T4B.
And T4B is the highest local stage. That sounds terrifying for a patient.
It is. But practically speaking, the label matters less than the physical surgery. If the sphincter is invaded, you usually cannot save it. You have to do an abdominoperitoneal resection, an amputation.
Meaning the permanent colostomy we talked about earlier.
Yes. So calling it T3 versus T4 isn't just about doing paperwork correctly. It's about determining the mechanical reality of the rest of their life.
There's another major gray area regarding the lumps in the fat. We talked about the comet tail, but what about the actual lymph nodes? The paper mentions this distinction between smooth and spiculated.
This is a crucial distinction that has really evolved over time. In the past, we just looked at size. Big node meant bad, small node meant good.
Seems pretty logical.
But MRI has taught us that morphology, the actual shape and texture of the node, matters way more than size.
So if I see a smooth, round node on my scan, even if it's really big,
Even if it's large and looks malignant, if it has a smooth, well-defined capsule, the Society of Abdominal Radiology says do not count it as involving the margin.
wait, really? Why? If it's full of cancer, isn't it an immediate threat?
It is a threat, but it's totally contained. The surgeon can usually just peel that node out safely because it has a firm shell. It doesn't stick to the fascia.
But what if it's spiculated? If it's spiky?
Spiculated is extremely dangerous. That spikiness implies the cancer is actively growing out of the node, breaking through the shell, and infiltrating the surrounding fat.
Oh, wow.
Those are counted as tumor deposits. If a spiky node is near the margin, you have to treat it aggressively with radiation because the surgeon likely cannot get a clean line around it.
It's truly amazing how much detail they can see on these scans now. It's not just is there a lump, but what is the microscopic texture of the edge of the lump?
It's revolutionary.
Now, for our final stop on this map, we have to travel a bit further out. We're going to look at the hidden pathways, the lateral pelvic lymph nodes. And this reveals a fascinating east versus west divide in medicine.
Yes, this is one of the biggest philosophical debates in colorectal surgery globally.
Cultural differences usually apply to, food or etiquette, not cancer surgery.
In this case, it's entirely about surgical aggression. In Japan, if you have a low rectal tumor, they routinely perform what's called a lateral lymph node dissection.
Which means what exactly?
They actually go deep into the side walls of the pelvis, way outside the normal saran wrap package, and systematically dig out all those extralateral nodes just in case.
So purely prophylactic surgery, kind of a let's get them before they get us mentality.
Exactly. But in the West, meaning Europe and North America, we've traditionally viewed that as far too risky.
Because of the nerves?
Yes, there are major nerves there. Digging around can cause severe sexual dysfunction or permanent urinary problems. So instead of surgery, we relied on sterilizing those nodes with radiation. We blast the whole pelvis, assuming the radiation will just kill any microscopic cancer in those lateral nodes.
But the source material suggests the Western approach might have a serious crack in the armor.
It does. This paper drops a bit of a bombshell for Western doctors.
Which is, let's hear the number.
Size matters, specifically the number 7.
7 millimeters.
Right. The data now clearly shows that for lateral nodes that are 7 millimeters or larger, radiation often fails completely.
Fails completely.
It doesn't kill all the cancer cells. Nearly 20% of those patients develop a recurrence in those exact nodes later on.
Wow. A 20% failure rate is massive when you're talking about cancer returning. You're sitting there thinking you're completely cured, but the radiation just didn't quite finish the job.
Exactly. It creates a sanctuary site for the tumor to hide out and regroup. This strongly suggests that the West needs to become a bit more like the East.
We need to start cutting them out.
For those specific patients with large lateral nodes, yes, Radiation just isn't enough. We need to go in and surgically remove them.
And for the radiologists listening, or honestly just the anatomy nerds out there, where are we actually looking for these? The paper talks about very specific compartments.
Yes. You can't just wave a hand and say lateral nodes. You have to be incredibly specific. There are two main zones to check.
Okay, what's the first?
First is the internal iliac compartment. These act as the sentinel nodes. Even small ones here, anything greater than 4 millimeters, are considered highly dangerous.
Then the second zone.
The obturator compartment. These are much deeper. And the paper gives a fantastic visual boundary for finding this. The infrapiriformis foramen.
Try saying that 3 times fast. What are we actually looking at with that?
Think of the piriformis muscle almost like a shelf running horizontally across the hip. It divides the pelvic space.
Okay.
Anything tucked underneath that shelf is in the danger zone, the obturator compartment.
So if you're looking at the scan and you see a node below the shelf, you know it's in that deep lateral system.
Precisely. And that's a massive red flag that standard surgery is going to miss it.
It really is a map. I mean, you have landmarks, exit ramps, shelves, border guards. It's incredibly detailed.
And understanding that level of detail is literally the only thing standing between a patient and a poor outcome.
So let's try to bring this all together for everyone. We started with the idea that anatomy isn't just a fixed street map.
Right. We've officially moved away from the blunt 15-centimeter ruler. We are now building a completely personalized map for each individual patient.
We find the sigmoid takeoff to define the top border. We find the Siegel, the APR, to see if we even need radiation. We check the envelope, the MRF, with that tiny 1 millimeter ruler to see if surgery will be clean.
And we closely check the spikiness of the nodes to see if they are actively invading the surrounding fat.
It's a total shift from just generic staging like T1, T2, N1 to customized surgical planning. The radiologist is no longer just reporting the news. They are actually helping write the battle plan.
Exactly.
Now, the paper ends with a thought that I found really, really provocative. It fundamentally challenges the way we think about lymph nodes entirely.
Yes. This is such a crucial point to end on. We spend so much energy worrying about whether a lymph node is hitting the margin, but the source points out something totally paradoxical.
What's up?
Lymph node involvement aggressively reduces overall survival, mostly because it means the cancer has the potential to spread to distant organs like the liver or the lungs.
Right.
But strangely enough, involved lymph nodes rarely cause local recurrence in the pelvis.
Wait, explain that. I thought we were cutting them out specifically to stop them from growing back right there.
It's a common misconception. A lymph node is usually encapsulated. Even if it is packed full of cancer cells, it rarely breaks open and causes the tumor to grow back right there in the empty pelvic space.
Oh, wow.
It's a marker of systemic disease. It tells us the cancer is already in the lymphatic fluid, moving around the whole body. It's not necessarily a local enemy that needs a wider and wider surgical margin.
So let me make sure I'm getting this. We might be obsessing over aggressively cutting out a node to, quote-unquote, save the margin, when the real threat is that the node indicates the cancer is already floating in the bloodstream.
Exactly. It suggests that our total obsession with local anatomy trying to cut cleaner, wider margins must always be balanced with the actual biology of the cancer. Sometimes the best knife is actually chemotherapy.
That is a fascinating shift in perspective, something to really mull over. It's not just about cutting it out. It's about deeply understanding what the anatomy is telling us about the hidden behavior of the disease.
Precisely. At the end of the day, we have to treat the patient, not just the picture.
Well, I will certainly never look at a Siegel or a ruler, for that matter, the same way again. There is just so much nuance here.
And that nuance saves lives every single day.
Thanks for diving deep with us today.
It was my pleasure.
We'll catch you in the next deep dive.